The following instructional video details placement of a central venous catheter in the internal jugular vein using ultrasound guidance. Some of the benefits of using ultrasound technique include decreased insertion attempts compared to landmark technique, decreased complications related to central line insertion, decreased central line insertion failure rates, increased patient safety when used by trained providers, and ultrasound guidance is a preferred method for inexperienced providers, as well as it increases knowledge of anatomical landmarks with repetitive use. Some of the contraindications to placing a central line include absolute contraindications, patient refusal, infection at the insertion site, anatomical variance at the insertion site, and superior vena cava syndrome. Relative contraindications include coagulopathy, systemic infection, and right-sided ventricular assist device. Sterile prep solution, a sterile drape, an 18-gauge intravenous catheter on a 5 ml syringe for aspiration, local anesthetic, a 3 ml syringe with a 25-gauge needle, a guide wire, a scalpel, vessel dilator, 3/0 suture, and central venous catheter with flushes and claves. A sterile occlusive dressing with biopatch should be available. You will also need to have available sterile gloves, eye protection, a face mask, and sterile gown. The ultrasound machine should be available along with jelly and a sterile probe cover. The patient should be in Trendelenburg position with full ASA monitors on. Emergency airway equipment and drugs should be available. Now let's go over some basics of the ultrasound machine. After powering up, it's important to orient your probe by touching one side and making sure it correlates with the same side on the screen. If the view on the screen is too dark, you may need to increase the gain by adjusting this dial. The internal jugular vein lies 2 to 3 centimeters below the skin, so the depth may be adjusted here to place the vessels in the center of the screen. Now identify the following landmarks: the mastoid process, clavicle, cricothyroid, the clavicular and sternal head of the sternocleidomastoid. A timeout should be performed to ensure correct patient, site, and procedure. Now, all sterile personal protective equipment should be donned, the CVL kit opened, and neck prepped with sterile solution for 30 seconds. The sterile drape may then be placed. Place a sterile cover and ultrasound jelly over probe. Be sure there are no bubbles between the face of the probe and the inner surface of the sterile sheath. This will prevent suboptimal imaging. Also apply sterile gel on the outside of the ultrasound cover for scanning. Using the ultrasound probe, you want to identify the internal jugular vein. Your probe should be in a transverse position inferior to the apex of the sternocleidomastoid heads. The internal jugular vein will lie lateral to the carotid artery and will be easily compressed with downward pressure from the ultrasound probe. The vein will be ovoid in shape and the artery round. If you're having difficulty visualizing the vein, you may ask an awake patient to perform a Valsalva maneuver or to increase PEEP on an intubated patient. This causes a dramatic increase in the size of the vessel. The carotid artery should not collapse, and you should be able to note pulsation on the ultrasound screen. Note that the carotid artery may overlap the internal jugular vein 54% of the time. 5.5% of the time, the internal jugular vein may lie medial to the carotid artery. The position of the patient's neck may also change the orientation of the vein to the artery. While holding the ultrasound probe transverse in the out-of-plane position, insert the 18-gauge catheter with bevel up at a 45-degree angle to the skin, aspirating as the catheter is inserted. You should note the catheter tip entering the center of the vessel on the screen and simultaneous blood return in the syringe. Thread the catheter onto the vein while removing the needle and syringe. You may want to cover the catheter hub with your thumb while you reach for the guide wire. Insert the guide wire through the catheter carefully. The guide wire should advance smoothly without resistance. Monitor for ectopy while the guide wire is inserted to a depth of about 12 to 15 centimeters. Once the guide wire is threaded to this depth, slowly remove the catheter over the guide wire, making sure not to release the guide wire. Confirm correct placement of the guide wire in the internal jugular vein using the ultrasound probe in the in-plane position. Once placement is confirmed, use the scalpel to make a small incision in the skin with the blade facing laterally, directly over the guide wire. This ensures that you are cutting away from the artery. Thread the dilator over the guide wire and remove, again making sure not to release the guide wire. Carefully thread the catheter over the guide wire, making sure it is held in place. Once the catheter is in place, remove the guide wire. Aspirate and flush the ports of the catheter and place a clave on the distal port. Suture the catheter in place and cover with biopatch and sterile occlusive dressing. A chest X-ray should now be ordered to confirm placement. Complications include minor hematoma formation at the insertion site, local infection, arterial puncture, and arrhythmia. Serious and rare complications include a major hematoma compressing the airway, major trauma to large vessels with hemorrhage, cardiac perforation with tamponade, pneumothorax or hemothorax, thoracic duct injury, sepsis, venous air embolism, nerve injury, venous thrombosis,